In this video, what we'll be going through is the answers to the questions that we posed in the previous video, where we talked about how the kidneys are supported on intensive care. Specifically, we were talking about what to do if patients' kidney function doesn't resolve and come back to normal once their acute medical condition that caused them to come to intensive care has resolved, i.e. they have developed chronic kidney failure. And we'll talk about different options for dialysing these patients. There are various different ways to do long-term dialysis. You would have seen in intensive care that we put in lines, and these lines go into the vein and suck blood out and then push it back in. And so you can put in these tunneled long lines that can sit in for months and months, years and years, and do exactly that. And that's what this looks like here. But you've probably heard of people having something called a fistula. Now, what you want to do with hemodialysis is you want to take blood out of the patient's body and you want to push blood back in. If anyone's had a blood test taken, you can see that it's quite slow to draw that blood out. It's because a vein has not got much muscle to its wall, and so it collapses if you put negative pressure on it. With dialysis, you need to suck the blood out quickly and then push it through the system and then push it back into the patient's body quickly. So if you would just try to take blood out of a vein, it would just collapse with the amount of pressure that it would need, the amount of suction that it would need to pull out blood quickly enough for the machine to work. And so, what we have instead is a surgical procedure that joins an artery and a vein together in what we call a fistula. And all we do as a surgeon with a fistula is we have the artery and we have the vein running next to it, and they connect the two up together. So now you have arterial blood coming down the patient's body, and it'll still come into the hand and perfuse it, but you'll get some of it coming back into the vein. So now you've got a much higher flow and much higher pressure of blood going through that blood vessel, the vein. And by doing so, by having that higher pressure and the higher flow, when you dialyse the patient, you can suck more blood out per unit time. And what this looks like after a while are these swollen areas here. And what those swollen areas are the much higher blood flow causes those veins to dilate up. And then, over a period of a few months, the walls of the veins become nice and thick and are able to cope with that high pressure. And then, what you can do in dialysis is actually put a little needle into these areas here. And you see that here. And one of these needles is going to suck blood up, and then another one is going to take the clean blood that's gone through the dialysis machine and push it back into the vein. So it does exactly the same as what this does, but rather than having a piece of plastic sticking in the patient the whole time, which is at high risk of developing infection and developing blood clots around it, you can make basically the same thing by joining an artery and a vein together. And the benefit of this is that there's no plastic sitting there, so the risks of infection are much lower. So this is how we do hemodialysis. And you can see here a picture of a patient who's on a hemodialysis machine. And you can see here the two lines. These are connected to needles that are punctured through the skin and into that big dilated vein that's connected to the artery. And then this part of it is exactly the same as what you saw in the last video where we talked about intensive care dialysis. It'll go through a machine, it pumps the blood through, and then it goes through a filter, which you see here, and then the filter forces fluid out and uses dialysis fluid to clean this blood and then put it back into the patient's body. Now, on intensive care, we often have patients running on a dialysis machine day and night, 24 hours a day. And that's because they're very sick and they've got underlying problems that cause their kidneys not to work properly and for them to produce a lot more toxins than normal. In patients who've come out of intensive care who are otherwise well, their bodies accumulate toxins at a much slower rate. And so rather than being on it 24 hours a day, you can have short periods of time where you clean the blood. And typically the regimes that they use are patients will come in on a Monday, a Wednesday and a Friday, or they'll come in on a Tuesday, a Thursday and a Saturday. So they only come in 3 days of the week. And for 3 days of that week, they will sit there for 4 hours and clean their blood out. So they'll get rid of any excess fluid and they'll get rid of the toxins that are in the body. So you can imagine that if you're dialyzed on Friday, you're probably going to feel fine because all of the toxins are gone. But by Saturday and then Sunday, all those toxins and fluids have started to accumulate. So these patients often feel quite rotten by the time it comes to Monday. And again, they'll start to feel great again after they've had their dialysis. Then the toxins accumulate over Tuesday. So by Wednesday, they're not feeling great. And then they're dialyzed again. So you can imagine it's quite difficult for patients. And also, 3 times a week, they'll have to come to hospital and spend 4 hours each time sitting on a dialysis machine waiting for their blood to be filtered. So it's quite a lot of work for the patient. It's quite a lot of work for the hospital that has to have these machines, nurses that are there to look after the patient, people to needle these fistulas to be able to take the blood out, and then to monitor the patients. And if you've got a huge number of these patients, it can get quite full, and that's why they stagger when patients come in. So half the patients will come in on a Monday, Wednesday and a Friday, and the other half will come in on a Tuesday, Thursday and a Saturday, so that they can stagger the number of patients. There are initiatives now where people can dialyze at home. It's very expensive, but you essentially buy a dialysis machine which patients then take home and leave at home, and then every night they can connect up to the dialysis machine and then dialyze as they sleep, or during the day, depending upon how they are. There are, however, alternatives to taking the blood out. Because if you can imagine, it must be quite painful each time having to needle the vein to try and get blood out, or by having to have lines in which can get infected. So the other way you can do it is something called peritoneal dialysis. Now, inside the tummy, you have a covering that covers all of the organs called the peritoneum. And this peritoneum acts like a semi-permeable membrane. There's loads of blood vessels around this peritoneum, and then this space is just a space. So if you fill this space up with dialysis fluid, so nice clean fluid with no toxins, what happens is as the blood flows through next to the peritoneal space, all of the horrible toxins are going to ease out. And so they're going to come out of the patient's body and into this peritoneal space if you fill it up with lots of fluid. So you can imagine if you leave it there for 6 or 8 hours, you're slowly going to get rid of the toxins that are in the blood supply and put it into this peritoneal space. So once you've left it there for a few hours, if you then drain it, that drainage fluid is now going to contain all the toxins. So you can see how you can actually get rid of a lot of the toxins from the patient's body without having to take bloods. But it asks the question, how do you actually put the fluid in? Well, you can put in something called a Tenkov catheter, which is a little plastic tube that sits inside the patient's tummy. And by doing so, you can then pour fluid in, and then you can use this catheter to drain fluid out. So this is an alternative to hemodialysis. And the nice thing about this is that you don't have to be connected up to a machine the whole time. You could, for example, put this fluid in at the start of the day, fill up your tummy, and then go about your day. And once you get to the end of the day, you can drain that fluid out and you've given yourself dialysis. But you haven't had to come to hospital every other day and have to sit in hospital for 4 hours on a machine. With this alternative, you can walk around. Now, it's not as efficient as hemodialysis, and you can imagine that if you've got a lot of fluid on board and you're not passing much urine, it's not going to get rid of a lot of fluid. So it's not the perfect option for a lot of people, but for some people it is a great option and one that they take because it gives them a lot more independence as patients. Now, the longer term solution, if you want to get off dialysis and lead a normal life, would be to have a kidney transplant. This is where either someone related to you or someone who's not related but donates their kidney to you, or if a patient dies and has a blood type that matches with yours, you can take their kidney and implant it into the patient's body, and then it just takes over the function of what the native kidneys would do. Interestingly, when we do kidney transplants, we don't take out the diseased kidneys. They sit up there in the top of the tummy. Instead, what we do is we open up a little bit near the pelvis, and then we connect the donated kidney to the big blood vessels in the leg, just as it supplies the leg, so in the pelvis. So where the donated kidney sits is actually within the pelvis, and that's great for two reasons. One, it's close to the bladder, so we can drain straight into the bladder. It's close to these really big blood vessels, so you can get really good blood flow to the kidney. And also the pelvis itself is a big bony structure, so it provides protection. So if accidentally people hit or bang into things, it's not going to damage the donated kidney. Now, this is obviously the long-term solution to not being on dialysis, but kidney transplants in and of themselves aren't a panacea. They require you to have regular anti-rejection medications, immunosuppressants. It makes you more prone to developing infections. And also, some patients can reject their kidneys because their immune system just detects that it's something abnormal and tries to start destroying it, even if you've matched them for blood group, because there are various other antigens on the kidney's surface which it might react to. So although it isn't a cure for everyone, if it works fantastically, and it can give patients a new lease of life, that they don't have to get connected up to machines to have peritoneal dialysis or have to come into hospital for hemodialysis, and they don't have to have fistulas, and they don't have to have the long lines put in. So it's a great option for those patients for whom they're eligible and we find a kidney that matches them. So in summary, renal replacement therapy can be done either similar to how we do it in intensive care, by taking blood out, filtering it and putting it back in, and we can do that through long lines, or we can make a special vasculature called a fistula, which can then be needled to take blood in and out quickly and efficiently. Or if you don't want to take blood out, you can do peritoneal dialysis, where we put clean fluid into the tummy and then we allow the toxins to drain into that clean fluid in the tummy, which then, once it's all equalized the amount of toxins there, we can then drain it out and get rid of it. The longer term solution is to do a renal transplant, which is great if it works, but there are a number of drawbacks to a renal transplant that need to be considered, such as long-term immunosuppression and the risk of rejection.